This was a 65-year-old gentleman, and he was within a couple of hours of his chest pain, lateral MI. Right was non-dominant, and there was significant disease in the distal. Also, I think moderate to significant disease in the proximal LAD. And some disease in second OM, but main culprit was the first. So first OM after thrombosuction, that's the result. I think decent result, all set to deliver a stent. So since there is a disease all around, so we thought just finish with the ostial stenting. A float wire there and position at the os, delivered the stent. That's the result. But look at the second OM. Second OM is also calling for intervention. So delivered a stent there, and that was the final result. So everything looked fine. Then I tried to image it. Difficulty in taking a imaging catheter into the first OM. I thought, forget about it. I can go to the second. It is trying to telescope into the OM1. So then finally I was able to take the catheter there. Well expanded stent, well positioned at the os. For the second OM, the first OM stent was doing a little bit of mischief, so I had to use a guide extension. With a BAT, guide extension is taken deep, and then an IVUS catheter, well expanded stent right at the os. So things were fine. I think the second one, now you can see it. So it looks a decent result. So it's a stressful wiring, little bit of skill, I think more of luck and some skill. That combination will take you somewhere. Let it go wherever it goes. And now the general tendency is in such a situation is to balloon these areas. And if you balloon this area, the advantage of ballooning is you can quickly have a flow. The disadvantage of ballooning is that you only shoot the thrombus distally. So what you can do is, since you have successfully wired, so you can go ahead with a suction. Thrombosuction catheter will be daughtering, which will almost always resume a flow, and will also suck a thrombus in case it is there. Of course, most of these patients, if you are into kind of CPR for some time, will invite some hemodynamic support, usually in the form of an ECMO, which was not there with us. So we thought thrombosuction and a lot of intracoronary epinephrine in the form of not diluted drops in the form of ampules. Ampules. I am saying ampules, not singular. I am saying in multiple. So I am into this business of working on cardiac massage. बिल्कुल ऐसा है जैसे आपको सुई में धागा डालने के लिए बोलते हैं, घोड़े पे बैठा दें और यहाँ पर आपके दो नाली लगा दें. अब देखो अब धागा कैसे डलेगा. Something of the same sort was with me. After a lot of struggle, some flow came. But the flow is just kind of entering in the coronary with your pressure. It's not getting out of it. Then I am trying to get into the circumflex. I am able to get into the circumflex and start doing the same thing. Now I start finding some flow, but again, it looks as if some air has also gone in. Because sometime, once you are taking your thrombosuction catheter with rush, you can take an air. But generally, I try to pressurize my tube boss chamber with a pressure from outside, so it is almost a guarantee that air cannot go in. So I'm continuing with thrombosuction. I'm already, I think, 20-25 minutes into it. Now, if I go back previously, then some people will say stented. Stent from where to where? Which direction? If you stent from LM to LAD, you are closing of circumflex. You go to circumflex, you are closing of LAD. Where will you land the stent? What will be the size of the stent? So all these issues, you have to see something before you want to deliver a stent. So finally came a time when we started to see something. Now you can clearly see a filling defect in the circumflex OM stent. And you also have telltale of thrombus everywhere. So most of the coronary tree is seen, but there is no mechanical activity. Mind it, no stent has been delivered so far. And whatever theory of possible dissection is there, first of all, if you have a dissection, the moment you pass 1 or 2 wires, you start having some flow. That kind of a thing is usually not there in a dissection. That 2 wires are there, still you don't have even a trickle of flow. So despite no stent, you start seeing the artery. So we started to give double bolus infusion of tirofiban because I was thinking that maybe it's a combination of both, but at least be aggressive with the thrombus also. I didn't have TNK TPA with me at that point in time. I would have shot that because I had nothing to lose. I was just losing the patient. Finally, this patient will be lost. So now we are seeing some exit of the dye into the LED. You started seeing some contractility. And of course, this is with high dose intracoronary ADR boluses. But you see a thrombus there? So I take a thrombosuction device into it and suck it. It becomes less. So now it's very sure that whatever it is, maybe there is a dissection also, but I think a large part of contribution of this whole syndrome is because of some thrombogenic environment inside. And despite the fact we are giving heparin, probably either that is not working or something else is there. I don't really know what it is. So at that time, I thought that I have given agramet to the patient, and it is possible I have asked for a thrombolytic agent that might be on the way. So I have sealed this perforation with a coil, but I am not very happy because this is likely to open. The moment the agramet effect comes, or you give a thrombolytic and a thrombolytic effect comes, it is likely to bleed again. So now that hemodynamics are fine, vessel is flowing, just take a microcatheter there, deliver one more coil, and I took a microcatheter there and delivered on one more coil, just to be very, very sure that I'm not bleeding from that area. So this is what it is now, a decent flow, decent hemodynamics. So I thought, I'm started to see the distal vessels. So I think I'm well set. And, but again, the blood pressure starts to fall. This shot tells you that sorry. If you look at this shot, it tells you that everything is wrong close to the guiding. So towards circumflex, you can agree, but we have nothing has visited the LED. No instrument has gone to the LED. But we know that plaques can be unstable all around. So it is possible, coincidentally, the other plaque is also unstable. And so LED was collapsing, if you see. Since the distal vessels are fine, so I thought now is a time for kind of bifurcation stenting. So I think we can finish this case by just doing a bifurcation stenting because things are fine.
What are the antiplatelets before tirofiban?
Huh?
Before tirofiban, what are the antiplatelets the patient was on?
As patient comes in emergency, they are usually given Brilinta and aspirin.
Brilinta.
Yeah, they were given.
Okay.
So the moment we thought that now things are fine, we'll just do a LM bifurcation stenting. Again, the patient collapses, and he's on CPR again, and you can hardly see anything. And it's very, very difficult to wire. Finally, I was able to wire into circumflex, balloon into circumflex, but hardly any flow. Pull out the wire from the circumflex, go into the OM second stent there and start ballooning into that area. And a lot of work, and after that, I start getting some flow. And with this flow, I thought, now is the time to stent it. So took a stent from LM os to the circumflex. Then did some part, and after having, this was a flow, then started to work in the LED with some balloon and made some way, and finally position the stent at the LED os and kissing, and that was the final result. And this was the final result, but we have already had decent flow and decent hemodynamics many times. But this time, if you look at it, between the two coils, you are seeing some flow. Can you see it? Can you appreciate? See that once only single coil was there. There was no flow even into that coil. Now, despite two coils, you have a flow which is, sorry. So you see that despite two coils, you have a flow. That means by now it is possible that the effect of tirofiban has started to come, and whatever was sealing it, that seal has been broken. So this was his left ventricle, and this patient was of course discharged alive and is fine. He didn't die. So my take home for this case are that anything which is looking simple can turn into complex. anything. A spring tip wire, workhorse wire, they can also exit. And sometimes you're not able to appreciate because your wire work in that area causes a spasm, and that small little vessel where the perforation had taken place, it had some tone, and it was not leaking so well because we had already clearly seen it. And somewhere the patient is out of the cath lab, that tone goes down, that irritation to the vessel is not there. So that may be kind of trying to cover it up. There's no doubt that we should all have an ECMO ready with us, just in case you have a total hemodynamic collapse, just to bail out these cases. But fact of the matter is that many times we don't have it, even in the best of the centers. Now, it is difficult to work on CPR, but let me tell you, you have to have commitment. Do not get irritated, just hold on to your nerves. If you hold on to your nerves, it is possible that sometime you will succeed. Because many times it is very irritating if you're doing massage, somebody is bringing, and then you try to lose your cool. I will say that best is not to get into these situations, but just in case you get into these situations, even CPR, prolonged CPR, which was done in this case for about half an hour. And tirofaban, of course, and like tirofaban, even thrombolytics can reopen, so one should be very, very careful about initial success in closing a perforation with coils, that you can lose the success, because sometimes we have seen these patients, everything has stopped, you send them to the ICU, they start collecting fluid again. So I think with those simple points,